Good morning, everyone. So I've got two problems this morning. Firstly, I have to follow a high energy performance like that, which is not easy. And secondly, I'm looking at the audience and I'm seeing my staff here. What are you doing here? If you're here and I'm here, who's looking after the place? All right, so we're going to talk about troubleshooting. So that's home for some of us. Okay, so in talking about troubleshooting, I want to talk about four main problems. The first one is hypotension. The second one is high airway pressure, then dyssynchrony, which is a fairly big topic, and lastly about desaturation. So when we're dealing with troubleshooting with a ventilator, the first thing to do is a bit like resuscitation. Firstly, you check your own pulse, and then decide whether it's an urgent problem or not. If it's an urgent problem, it needs urgent attention. If it's not, you can call for help. Okay, so if we look at this patient with blue lips, chest not moving, saturation low, and hypotensive. So that's an urgent problem and needs urgent attention. Okay, once you've decided whether it's urgent or not, we need to decide whether it's a patient problem or a ventilator problem. Okay, and in this situation I find, and I always try and teach residents, that the ambu bag is your best friend in this situation. If you can't decide whether it's a problem with the patient or the machine, disconnect the patient, put them on an ambu bag and use that bag. You get a feel for what's happening as you squeeze the bag. You're giving a delivered high concentration of oxygen, and you can work out the problem and not be distracted by what's going on with the ventilator. Too many times I've seen patients being dealt with a person looking at the machine with his back turned to the patient, fiddling with buttons and a lot of alarms going off, and there's a blue patient behind him, totally unaware because he's too busy with the machine. Disconnect the patient from the machine and use an ambu bag. The other thing is to know which machine you're working with. Right? Not all the machines are equal, as you can see. There's older machines which are in circulation still, unfortunately, in our hospital also. There's newer machines. They don't all work the same, and you need to know what the buttons do. Okay, so addressing the first problem when we're dealing with troubleshooting. Hypotension in ventilated patients is a fairly common problem. Right? In the beginning, when patients get put on positive pressure ventilation and we increase intrathoracic pressure, that may unmask a hypovolemic situation, and the patient presents as hypovolemic immediately after commencing mechanical ventilation. We use drugs to initiate ventilation, and a lot of those cause hypotension by vasodilation or myocardial depression. Pretty much anyone you can think of, propofol or midazolam or any of the others, causes hypotension in this instance. Ketamine is less vicious in this regard. Dynamic hyperinflation with air trapping in the lungs can cause hypotension, and we should be aware of that. And here's an example in the graph just showing you what we mean by that. So the patient's unable to exhale the previous breath before the next one is delivered, and with each breath accumulates more gas within the lungs, and that causes hypotension because of decreased venous return. As Ronnie mentioned in the first lecture, the best thing to do in that situation, again, disconnect the patient. You can hear the air escaping from the lungs, and you see the blood pressure return and the pulse return in some instances. Okay, tension pneumothorax is a cause of hypotension and catches us unawares not infrequently. Clinical examination to determine tension pneumothorax is not that accurate. So if you suspect it, get a chest x-ray as soon as you can and make preparation for inserting a chest drain. Okay, so that's hypotension is one of the first problems we might encounter in a ventilated patient. The next one, which is commonly seen and causes all the alarms that you hear in rooms throughout the hospital, you behind curtains, around corners, in cupboards, find patients on ventilators with alarms going off because of high airway pressure. Now, there are many causes of high airway pressure, and we'll look at some of them now. Okay, so why do we care about it? Okay, high airway pressure, so what? It might just be that the alarm is set a bit too low, but what we're concerned about is that we might be causing barotrauma to patients, so we want to avoid that. The fact that we have an airway alarm might mean that there's been a change in the patient's condition. Like there's a sputum plug which needs to be suctioned out, there's a pneumothorax which needs to be dealt with, or that we're causing inadequate ventilation because the airway pressures are rising and the tidal volumes being delivered are too small. So that's why we care about airway pressure, because it's an indicator of something else which might be going on. Okay, and in these graphs we can see, so that on the left side there, the pressure being delivered looks normal. There's a peak airway pressure, there's a plateau pressure. The volume on the bottom row there looks okay. And then if we set an alarm and we reach that peak airway pressure, the ventilator turns off when it reaches that alarm limit, and the volumes delivered drop off, as we can see on the bottom graph. So minute ventilation decreases, CO2 rises, and all the consequences of that. Okay, as we've said already this morning, some of the ventilators measure the pressure actually in the ventilator. Okay, which is far away from the situation of actually where the pressure should be being measured, which is in the trachea, but we need to be aware of that. So airway pressure problems might be because of inadequate ventilator settings or inappropriate ventilator settings, or measurement inside the ventilator which is not giving us an accurate reading. Okay, the physics we've seen already. So airway pressure is related to all those factors that you can see there: flow and resistance in the delivery tubes, volume, compliance, and PEEP within the alveoli. Okay, so inappropriate settings then can result in high airway pressures or excessive tidal volume. So when I started training, which was a little bit after when David started training, it was very simple, especially doing anesthesia. It was the rate of 10 per minute, tidal volume 10 milligrams per kilogram, and FiO2 of 0.5. That's easy to do. And anyone could remember that, and a lot of patients got ventilated like that to their detriment and ours. So excessive tidal volume is no good and can cause high airway pressures. Excessive inspiratory flow, which results in delivery of a big tidal volume, again, can do the same thing. Or if you have an excessively short inspiratory time, you try and deliver the volume or the pressure in a shorter time, can cause high airway pressure. Okay, so then we need to decide if we have the high airway pressure alarm, whether it's a ventilator problem or a patient problem. So if you're looking at the ventilator side of or the equipment side of the equation here, as you can see, it could be inappropriate settings, could be inappropriate measurements of the pressure, could be a problem with the tubing. Okay, you've got a kink in the tubing, you've got too much water in the trap, which is causing blockage. You haven't changed the filter in a couple of days, and that's all clogged up. All of these can cause high airway pressures. Or it could be a patient problem, and we'll come to some of those in a moment, which can be causing the high airway pressures. And the problem is to differentiate between the two and to treat appropriately. Okay. So patient problems that can cause high airway pressures and which need to be factored into any sort of assessment of the patient are increased resistance. Now, increased resistance could be anywhere from the end of the endotracheal tube all the way into the lungs. It can be due to bronchospasm, so smaller airway resistance. Changes in compliance. So, and again, if you have a sort of algorithm in your head about where you're going to work out where the compliance change might be, it might be in the lungs, pleural space, chest wall, or changes in lung volume such as atelectasis. Okay, pneumothorax can do it as well. And here we can see pneumothorax, which has been treated with a chest drain on the right, which would have caused high airway pressures. And if we hadn't thought of that as one of the possibilities, wouldn't have been diagnosed, and the patient could have come to great harm. Okay, so again, chest wall problems, for instance, burns patients with scarring of the chest wall, obese patients, problems with the chest wall can all cause changes in compliance and resistance and high airway pressures. Okay, and here's an example of atelectasis with right upper lobe atelectasis, which can cause a problem as well. Endobronchial intubation, I remember an incident, and it's amazing that you learn from everyone you work with, which is great. So I was working in England at the time, and we were working in 2 hospitals. And I was sitting with a senior guy in the one hospital, and he got a call from the junior person in another hospital saying, I've intubated this patient, and she was absolutely fit and normal and well before, and now the saturation's a bit low and the airway pressures are high. And he didn't think twice. He said, just pull the tube back 2 centimeters and tell me what happens. She did pull the tube back 2 centimeters out of the right main bronchus, patient ventilated entirely normally. But, if you haven't seen it before, you haven't thought of it before, you can't do it. But he could diagnose it over the phone, and it was fixed up. Here's an example of right endobronchial intubation with left-sided atelectasis. Okay, there's one thing that you can do from that equation you've seen several times this morning. If you're trying to work out whether it's a flow resistance problem in the tubing or the airways, or whether it's an alveolar problem causing high airway pressures, you can actually do an inspiratory pause. So you stop the ventilator on inspiration and you allow the pressures to equilibrate between the ventilator and the machine, and then the airway pressure and the alveolar pressure equilibrate. And if they're close to normal, then you know that that's not the problem. If the pressure remains high and the airway pressure remains high, you know it's an alveolar problem which relates to volume, compliance, and PEEP within the alveoli. So it helps you to differentiate the sort of tubing conductance problems versus the alveolar problems. And it's easy enough to do. Okay, so you measure the airway pressure during end inspiration, and it'll give you some idea of what the peak alveolar pressure is. And another thing which is easy to do is to look at, on the pressure time curve on the ventilator, look at the peak airway pressure and the plateau pressure. So the difference between them will give you some idea of the resistance in the system. So the higher the difference, the more resistance, and the closer they are, the less resistance. Okay, now dyssynchrony is probably what we deal with most of the time. Why we see ventilated patients having problems is because of dyssynchrony between the ventilator and the machine. I mean the machine and the patient. This is what it's like dealing with a dysynchronous patient at times. We try, and then we think we're succeeding. Everything's going really well. So just when we think we're really smart and we know what's going on, that's when we meet the first problem, okay? And you notice the lion's just waiting there. That's exactly what's waiting for us as well, the tension pneumothorax, all these problems. Now, okay, so what are some of the causes of dyssynchrony? Why patients are not coping with the ventilation being delivered to them? First one is agitation, right? So look for and treat the causes of agitation, and these include things like pain, plain discomfort, patients lying in an uncomfortable position in the bed, full bladder, full rectum, all of these things. Just treating the small cause can cause a lot of improvement in ventilation. Look at the mode of ventilation, so choose something which is appropriate for that patient's condition. So to try and give someone controlled ventilation, either volume or pressure controlled ventilation when they're trying to breathe spontaneously, is not in their interest. The IE ratio, as David said, if it's not set appropriately, can cause a big problem, especially as the patient starts to breathe more on their own. And look at the triggering. How hard is it for the patient to work to get his next breath? So is the trigger set appropriately? Too easily or too difficult is not a good idea in this situation. Okay, consider sedation. That's the last possible answer. After you've tried all the other things and you've bumped your head into the tree, and there's no other option, then increase sedation. And if you really don't have any other option and those lions are encroaching, then you might want to paralyze the patient as well in order to maintain some sort of synchrony and be able to ventilate the patient. But that's in a very small proportion of patients, and certainly it's not standard practice when there's so many other options available. Okay, so just to finish off, you need to have in your head some sort of idea of how you're going to deal with a patient when they're having trouble being ventilated. So if you have a patient who's desaturated, the first thing to do is to give an adequate amount of oxygen, and it's easy enough to give 100% oxygen on the ventilator. Then decide, is the chest moving or not? Okay, that's very simple to see. You can actually look at it and you can listen. It takes 1 second to make that diagnosis. If the chest isn't moving, okay, that's when your ambu bag comes into play. You disconnect the patient from the ventilator and you squeeze the ambu bag. If they're easy to ventilate on the ambu bag, then it means you've got a ventilator problem. Okay, and then you can spend your time while squeezing with one hand or while someone else is squeezing the ambu bag, you can fiddle with the ventilator to your heart's content while the patient is safe. If they're not easy to ventilate, then you need to consider if there's an endotracheal tube problem, patient problem with resistance or low compliance, something that's changed in the patient which has caused the problem. Okay, you need to treat the cause, like the tension pneumothorax, and then adjust the ventilator settings appropriately. So first thing, is the chest moving or not? If it's not moving, ambu bag, and then decide if it's easy to ventilate or not, and that'll help you to differentiate between patient and machine problems. Okay, if the chest is moving, you've got a bit more time. So you're 100% oxygen, saturation's adequate, and then you can start looking for the other problems. In particular, look for the endobronchial intubation on the right side, look for the pneumothorax, look for other causes of collapse in the lung, like atelectasis, things like pulmonary edema or bronchospasm. Patient's condition might have changed. You said to the staff to give 2 liters of fluid that day, and they got 2 liters, plus they got the TPN, plus they got all the antibiotics, and it ended up being 5 liters. Okay, I mean, how often does that happen? Too often, unfortunately. And so there might be pulmonary edema because we haven't sort of factored in all the other things. So then you treat the cause and adjust the ventilator settings for the new situation which has occurred. All right, so this is a simple algorithm, the last 2 slides that I've shown you. And I'd commend them to you because they're good to have in the back of your mind when you're faced with a patient that's in trouble. Okay, so the key points from this is always look at the patient first. Don't get distracted by the machine that's making a noise. Look at the patient first and see how much trouble they're in, and then try to distinguish whether it's an equipment problem or a patient problem. And have in your head some sort of algorithm to go through very simply in order to differentiate between those two and to be able to address the problems adequately. Thanks very much.